Alright folks, so today I'm going to be discussing gallbladder and pancreatic issues. So to start off, let's describe real quick, let's go over the basic anatomical terms and location. So the gallbladder is located in the right upper quadrant. It's located on the, usually below the liver, but within the confines of the liver space. And then we have the cystic duct that transports bile from the liver into the common bile duct, which eventually makes its way into the duodenum. And keep in mind that the common bile duct is shared with the pancreatic duct, which also releases its digestive enzymes into the duodenum. So we can have emulsification of fat by bile. So you guys need to remember that bile emulsifies fat. And emulsification is a word that we use to describe when, since fat and waters cannot coexist with one another, they kind of separate. You think about a cup, you sprinkle some oil on it, it's you see the globules of water not being mixed in, you see the globules of fat not being mixed in with the water. That's essentially the innate tendencies of fat. But bile allows the bile substance to get into the actual fat globules, and it breaks them down. And that whole breaking down of fat is the emulsification part, which allows it to be absorbed by the lipase that's dumped into the duodenum by the pancreas. It's also important for you guys to remember that we have bilirubin that's being excreted through the bile, and the bilirubin is the waste product of worn down RBCs, and it tends to be yellow/orange in its pigmentation. That's why whenever we have any issues with the gallbladder or with the pancreas not being able to release its element into the duodenum, we usually have the patient that develops jaundice. Keep in mind that we also should know that there's a hormone called cholecystokinin. And this is a hormone that the duodenum releases at any time it is confronting anything that's fat in the diet. So anytime we consume anything that's fat, cholecystokinin is released. It's a hormone that triggers the gallbladder to contract and release its bile so it can emulsify the fat. The bile gives us our stool color. So stool color, or its pigment, is very important, and we get it from the release of bile as it mixes with the food that we consume so it can be excreted. So whenever we have any bile issues or any type of outlet issues where the bile cannot get into the duodenum, keep in mind that we're going to have light color stools because of that particular reason. Moving on to the pancreas. The pancreas is very important because it releases digestive enzymes like we discussed in the previous video. And digestive enzymes are important because they help us break down and absorb the end product of carbohydrates, and that's carried out by amylase. It helps us absorb the broken down products of proteins, and that's carried out by trypsin. And then we have the absorption of the broken down products of carbohydrates, which eventually will become glucose, sugars, and I'm sorry, that was amylase. Fat now, and that's lipase. So for those of us that are confused, make sure you guys remember that amylase is for the absorption of carbs, trypsin is for proteins, and lipase is going to be for your fats. Okay, these digestive enzymes are inactive, meaning they're not breaking down anything until they actually are released into the duodenum, where they mix in with other elements that activate those enzymes, which then therefore help with digestion of all those food items. So the whole purpose of the pancreas is to release those digestive enzymes so they can mix in with the food and therefore be absorbed in the small intestine later on. We have something called the acinar cells. And the acinar cells are the ones that help us produce these digestive enzymes. Okay, and those are outlined by these little orange, little arched diagrams that I put up here. And we also have these blue ones. Those are representing the islets of Langerhans. And the islet of Langerhans play more of a role in the endocrine function versus exocrine function, which is outside the body, which is the opposite of the endocrine function, the islet of Langerhans, which are endocrine system inside the body, and that releases your glucagon and your insulin. However, those go directly into the bloodstream. As you guys can see, I drew blood vessels here because that's how we are able to release glucagon and insulin. They have a systemic effect, as opposed to your exocrine function. The digestive enzymes go through these ducts into the actual duodenum, mix in with the food items, and that's how we have digestion. It's important to note that, again, the common bile duct is the end term is you have a smooth muscle, and it's called you have a little muscle, a little sphincter, and it's called the sphincter of Oddi. And this is really important because research suggests that the sphincter of Oddi can begin to spaz when somebody is receiving morphine. So because of that, when patients have pain issues that deal with gallbladder issues or pancreatic issues, that of course you know that it's going to affect the sphincter of Oddi, we don't give morphine, we give Demerol, because it can cause contractions and a lot of pain, and it'll exacerbate the issue. Now, to begin a discussion of the disorders, you have to keep in mind all these elements that we discussed. What does the gallbladder, what does the pancreas do? When you know what those organs do, you start developing a clear picture as to what's going to happen when those functions are no longer intact. So let's start off with gallbladder issues. In gallbladder issues, we can have two primary issues. We can have cholecystitis, which is inflammation of the gallbladder. And that can be secondary to stones or just infection. So the manifestations of cholecystitis is going to be usually discomfort or pain in the right upper quadrant, because that's where the gallbladder is located. We can also develop cholelithiasis. Now the lithiasis part is what should remind you guys that it means or it defines stones. So we're talking about gallstones. Now the stones can be anywhere inside the gallbladder. It could be in the cystic duct and the common bile duct. It can be anywhere in those locations, but keep in mind the pain is still going to be manifested in the right upper quadrant, because that's where those structures are located. Now, to diagnose these conditions, when somebody comes in, you're going to understand, first of all, your assessment. Your assessment is going to include nausea, vomiting, especially postprandially, meaning after your meals, in particular with anything that has to contain fat, because fat stimulates the release of cholecystokinin, which causes the excretion of bile from those ducts into the duodenum. So the patient will the patient will verbalize that they have an increase in pain whenever they consume elements that contain fat. Okay? There is a procedure called endoscopic retrograde cholangiopancreatography. It's a mouthful. That's a mouthful, right? That's one word. Well, not so much. Endoscopic is one word. Retrograde cholangiopancreatography. Well, this is an endoscopic procedure, a procedure that goes inside the body through the mouth. Okay. Retrograde. The scope goes in this way, and it actually starts making its way through the sphincter of Oddi, and it can be allowed to secrete contrast medium into the ducts, so we can then take diagnostic imaging and find out if there's any obstructions, is there any kinks, any type of inflammation, anything that gives us insight that there's an abnormality in those structures. So that's what this procedure is. Keep in mind that in some seldom instances, this procedure itself can actually cause issues with the pancreas, like pancreatitis, but that's just a small percentage of people. We'll discuss the most common causes in just a bit for pancreatic issues. Continuing with gallbladder issues. If the patient has cholecystitis or cholelithiasis, the way that we find out what it is through this procedure, the endoscopic retrograde cholangiopancreatography. We inject the contrast medium, we visualize it, we find out where is our problem, where is the obstruction, do we have stones, do we have inflammation. At that point, we start talking about potential interventions. Generally speaking, pain is going to be one of the most important things that we deal with right now. We don't give morphine, we give Demerol. We also can start talking about the removal of the stones. Now, how do we remove the stones? There's something called lithotripsy. And lithotripsy is when they use sound waves to pulverize the stones, so eventually they can be broken down into smaller particles and then excreted normally, okay? When that doesn't happen though, then we have to go ahead and start thinking about more aggressive means of removing the stones if that's gonna be the issue. So we also have the cholecystectomy. Now the cholecystectomy can be carried out in two primary ways. We can have open, or we can have a laparoscopic procedure. Now, an open cholecystectomy is when we create an incision, a surgical procedure. The patient's going to be under general anesthesia. They're going to go ahead and open the patient's abdominal cavity and remove the gallbladder or any of the structures that are affected, and then we sew them up, right? Another option outside of open would be a laparoscopic procedure. Now, a laparoscopic procedure is less invasive. It doesn't require all the post-op assessments or the potential complications that an open cholecystectomy will have to be observed for. For instance, if somebody has an open laparoscopic procedure, they're going to have to think about general anesthetics, right? So the patient's going to be having pulmonary stasis, venous stasis, the likelihood of them not waking up after the anesthetics are worn out. So because of all those potential complications, we have to worry about teaching the patient to cough and deep breathe afterwards every hour once they're awake. You have to place the sequential stockings, the Ted-Ho stockings. You have to look out for DVT formation secondary to venous stasis. All of those complications can lead to the patient developing an unsuccessful surgical procedure, and it can cause DVT. It can cause pulmonary embolism. It can cause one in the brain, and it can cause atelectasis. So because of all those potential issues that we're going to be encountering with anyone who undergoes general anesthesia, we have the laparoscopic procedure. The laparoscopic procedure is when we create a few incisions in the abdominal cavity. We inflate the abdominal cavity with carbon dioxide, not oxygen, because oxygen is flammable. And when we cauterize the tissues in there, we might cause a little explosion. So we use carbon dioxide to inflate the abdominal cavity. And the doctor will put a scope inside that he or she will be able to visualize it and remove the structures that are being affected. With that being said, after a laparoscopic procedure, there's going to be some little steri strips that are placed on the abdominal cavity, but the patient may complain about some type of right shoulder discomfort. This is very common in laparoscopic procedures because the CO2, the gases, are irritating the nerves that innervate with the nerves that go to the shoulder. So the patient may complain of shoulder pain after a laparoscopic procedure. And remember, we don't give morphine, we give Demerol. Patients with this condition can be asked to ambulate, move around a little bit, so we can hopefully expel those gases from the cavity and decrease the effects of that potential shoulder pain. All right? Now, after we carry out any of these procedures, it's very common for the patient to have something inserted, something called a T-tube. Now, the T-tube is important for you guys because it's a high NCLEX topic. The T-tube is where we surgically insert a tube that kind of looks like this. Okay, this part of the top part of the T goes in here, like such, and then the other part comes outside of the body. Let's pretend these are the incision sites, and it's coming outside of the body, right? Now, the whole purpose of the T-tube is to redirect the flow of bile. You understand that after any type of invasive procedure, there's always going to be secondary inflammation. And because of that, you want to place the T-tube, the surgeon will have a T-tube in place, and you as a nurse have to monitor that T-tube and know what to expect. No more than 500 mL should be excreted per day, first of all. Second of all, as the patient has the T-tube, we're redirecting the bile outside the body into a little bag, and the bag should be placed below the level of insertion so gravity can help pull that bile out. It's also considered part of the output. Another thing you guys need to understand is that this T-tube is very important for the healing process, right? we use it to redirect the bile, but also to test to see if the patient is now being able to tolerate meals. So what type of foods is any patient that has gallbladder issues going to reduce in their diet? It's going to be fat, because remember, fat releases cholecystokinin. Cholecystokinin contracts the gallbladder, more pain, right? So after this surgical procedure, we don't want the gallbladder to be releasing all that stuff if it's even still there. We usually remove it so the secretions are very passive afterwards. There's nowhere for that bile to be stored. So you're going to have constant secretions of that bile, which may irritate this whole structure because there's going to be inflammation secondary to the invasive procedure of removing the tissues, right? So we redirect them outside. We monitor that output. We keep it below the level of insertion for gravity to help us. And as the days go by, the patient is going to be able to tolerate foods. So once the patient's able to tolerate foods, we put them on a diet. Usually it starts off always with a clear liquid diet. Then it's going to be a full liquid diet. And depending on what the patient's able to tolerate, we start giving them more and more elements that are included in our essential nutrients, right? But we're going to go easy on the fat. However, the patient needs that bile, some of these elements to be able to digest the foods that we're consuming. So there's going to be a little valve that we can open and close. And that will either help with the redirection of the bile out the body or keep it inside. Now, while the patient's eating, you're going to adjust that valve in such a way that it allows the secretions to enter the digestive system so we can have some degree of digestion. That's ultimately the goal, right? But if the patient's consuming foods and suddenly I have acute severe pain, that means that secretion now is irritating the tissues, and we're going to have to switch the valve so it can redirect the outflow of the bile back into the bag to allow the area to heal. I hope that makes sense, guys. So that's why the T-tube is very important. We can also use the T-tube to inject contrast medium, do another diagnostic image, and we can find out if there's any remnant stones, if there's anything left inside that may be causing the actual pain. All right? Now, when the patient has gallstones, generally speaking, we use that lithotripsy that I was talking about, the sound waves. It pulverizes the stones. Hopefully we excrete it out. Remember that bile gives our stool its beautiful brown color, and when we have gallbladder issues, whether there's anything that makes there be anything that contributes to an obstruction of the outflow of bile, is going to change the color of the stool. So those will be red flags. Those will be your clinical manifestations. If you understand the concept, what the bile is supposed to do, you're going to understand what's going to be manifesting in the output, such as stool or BMs, right? Another thing you guys need to understand, if there's some type of obstruction in the gallbladder tubes, in the tubing, well, the bile is going to start backing up. This will increase the backing up of that bilirubin into the bloodstream, and the patient is going to start developing jaundice, icterus. So those are all clinical manifestations